Welcome to the 106th meeting of the National Advisory Council for Nursing Research. I'm going to share my screen. All right, and I trust someone will let me know if I was not successful. So again, good morning. A special welcome to all of our council members and to the NINR scientific community. We're continuing with virtual meetings this round, and thank you for joining us online today. To ensure a quorum for this meeting, Dr. Rassouli, who is the Advisory Council Executive Secretary, will do a roll call. Dr. Rassouli.
Thank you and welcome. For the purposes of our recording and for our note taker, I'm going to ask you to just acknowledge when I call your name so we have a record of your attendance. So Dr. Atkins.
Hi, good morning.
Good morning. Professor Dawe.
Good morning, present.
Welcome. Dr. Fitzpatrick.
Present.
Dr. Johnson.
Good morning, I'm here.
Dr. Lee.
Good morning, I'm here.
Dr. Lewin.
Good morning, I'm here too.
Dr. Lowe, welcome.
Greetings.
Dr. Paragallo-Montano.
Here, good morning.
Dr. Monroe.
Good morning.
Dr. Provencio Vasquez.
Good morning.
Dr. Stone.
Here, good morning.
Dr. Zanton.
Good morning.
And Dr. Wolf.
Good morning.
And finally, Dr. Sullivan.
Yes, good morning.
Welcome all. Shannon, we have a quorum.
Excellent. Thank you, Dr. Rassouli. So let's get started. We'll jump right in and go over a few of the logistics for today's meeting. Just a reminder to please mute yourself when you're not speaking to eliminate background noise. This is a one-day meeting only. Closed session will begin about 15 minutes following the end of open session. A separate meeting invite was sent out to council members and all applicable staff with login instructions for that separate session. So first, we'd like to welcome 5 new individuals as ad hoc council members for this round. I'm excited to have these members with us today and the breadth of experience and expertise they bring to our council. So I'll tell you a little bit about each of them. Dr. Bob Atkins is the acting dean of the College of Arts and Sciences at Rutgers University, Camden, where he is an associate professor of nursing and childhood studies. Previously, he served the Robert Wood Johnson Foundation as National Program Director of the Foundation's statewide grant-making program, New Jersey Health Initiatives. He is a former school nurse in the city of Camden and has spent his adulthood working to build healthier, more equitable, and more resilient communities through service, scholarship, and education. Professor Dawe serves as Executive Director of the Satcher Health Leadership Institute at Morehouse School of Medicine and is a professor of health law, policy, and management. He is a health equity scholar, health policy expert, educator, and researcher whose work focuses on health reform, health equity, mental health inequities, social and political determinants of health, and health system transformation. He is the author of 2 health policy books, 50 Years of Obamacare and The Political Determinants of Health. Professor Dawe is an elected member of the National Academy of Medicine and an elected fellow of the New York Academy of Medicine. Dr. Fitzpatrick is a professor of pediatrics and nursing at Emory University. Her research has established that pediatric asthma is more heterogeneous than previously thought, leading to varied responses to one-size-fits-all treatment approaches. She advocates for pediatric asthma patients and for personalized or precision medicine through roles in national and international organizations. Her work on biomarker identification is leading to new and more effective ways to manage treatment-resistant pediatric severe asthma, which can improve healthcare outcomes and decrease healthcare costs. Dr. Patricia Stone is the Centennial Professor in Health Policy at Columbia University School of Nursing. She directs the School of Nursing Center for Health Policy and the NINR-funded Center for Improving Palliative Care for Vulnerable Adults with Multiple Chronic Conditions. Her research aims to enhance the quality of care for vulnerable adults, including preventing healthcare-associated infection and improving infection management and end-of-life care. Her program of research has contributed to policy changes like state and federal legislative mandates that hospitals report infections. She's also dedicated to teaching the next generation of nurse scientists how to lead interdisciplinary research teams that generate knowledge, influence health policy, and improve patient and population outcomes. Dr. Sarah Zanton is Dean and the Patricia M. Davidson Health Equity and Social Justice Endowed Professor of the Johns Hopkins School of Nursing. She holds a joint appointment in the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. Her main research strands are improving health equity among older adults, aging and community, the effects of financial strain on health, and structural racial discrimination and resilience. She co-developed the Capable program, which combines home repair services with nursing and occupational therapy to improve mobility, reduce disability, and decrease healthcare costs. The program has been tested in randomized trials and scaled to 45 new sites in 23 states. So please join me in welcoming all 5 of these ad hoc council members. Today, we're also thanking 2 departing council members for their service to NINR and our advisory council. This is the final meeting as council members for Nena Pargallo-Montano and Dr. Kai Moore. I've so appreciated your thoughtful counsel, and I look forward to opportunities to working together in the future. So this virtual only meeting is being broadcast live and will be archived via videocast. Minutes of the meeting from September were made available to you in the electronic council book for your review. So may I have a motion to approve?
This is Mallory. I move to approve the minutes.
Thank you, Mallory. May I have a second?
This is Christopher Lee. I second.
Thank you. Any discussion of the minutes? Okay, any opposed? All right, the motion carries. Thank you. Dates for future council meetings are listed on the NINR Council website, as well as in the open session materials and the electronic council book. Please review and let me know if you have any known conflicts with those dates. Our next meeting is scheduled for May 24th. I want to remind you that as special government employees, council members may not engage in any lobbying activities while receiving pay from the federal government. Further information regarding conflict of interest and confidentiality requirements are posted in the electronic council book, so please review if you haven't already. Dr. Rasuli will be giving more instructions, specific instructions about conflict of interest and confidentiality at the beginning of the closed session later this afternoon. Once a year, we review as well with our council members the council operating procedures. A copy of Council's operating procedures for 2022 can be found as well in the electronic council book. They are unchanged from last year, except that we have modified the language about which applications will be considered for special council review. We changed the language to refer to an NIH threshold rather than a dollar figure in case the NIH threshold changes. So I'd like to call for a vote to approve these procedures for 2022. May I have a motion?
Pat Stone, I motion to approve.
Thank you. Thank you. A second?
Cindy Monroe, I'll second.
Thank you. Any discussion? Okay. Any opposed? Okay, the motion is approved. So I'm pleased to now share with you my director's report. And I want to start by sharing a look back on fiscal year 2021 by the numbers. We provided nearly $140 million in funding to investigators through nearly 400 grants. NINR participated in 57 funding opportunity announcements. NINR staff were at the table for 213 different NIH, HHS, and government-wide committees and work groups. I participated in over 90 talks, keynotes, commencement speeches, congressional briefings, podcasts, and other speaking engagements. Most recently, in December, we posted notices of intent to publish 3 funding opportunity announcements. This included an R01 and an R21 for advancing integrated models of care to improve maternal health outcomes among disproportionately impacted populations. We estimate these announcements will be published in early February with an estimated application due date in April. We also posted a notice of intent for R01s evaluating the impact of COVID-19 pandemic-related food and housing policies and programs on health outcomes in individuals, families, and communities from health disparity populations. We estimate that this announcement will be published later this month, with a first estimated application due date in April. All 3 of these FOAs were developed from concepts that the Council approved at the September meeting. You can find more information on these notices on our website. And since September, we've also signed on to 18 additional funding opportunity announcements. As you might expect, some of these opportunities address the ongoing COVID-19 pandemic. For instance, NINR is one of 11 ICOs to sign on to a notice of special interest, highlighting the need for research to address vaccine hesitancy among populations that experience health disparities. Though not limited to the SARS-CoV-2 virus, we know that vaccine hesitancy is an ongoing issue in fighting the pandemic. With this notice, we hope to examine community-engaged interventions, evaluate policies and initiatives that mitigate or exacerbate disparities in vaccine access, uptake, and series completion, and understand and address barriers to increasing reach, access, and uptake of vaccinations. Additionally, NINR and other NIH institutes, centers, and offices are participating in an initiative on social, behavioral, and economic impacts of COVID-19 in vulnerable and health disparity populations. So that group issued a NOC to support research in this area. Now, one study NINR has already supported through this mechanism is examining whether an intervention in South Carolina for both African-American COVID-19 survivors with underlying chronic conditions and their informal caregivers is effective in improving health and quality of life for both partners of the dyad. The intervention will focus on overcoming racial and pandemic-related stressors in the context of community social vulnerability. Another study is examining whether intensified community referrals to address social needs of patients as part of their discharge from an emergency department setting improves general health and COVID-19 related health outcomes. As always, you can find more information at the NIH Grants website. And of course, we continue to support research outside of COVID as well. Examples are shown here. We recently signed on to an NIMHD-led FOA to support research on the effectiveness of school-based health centers as a health services care delivery model to address the needs of underserved youth. And we've expressed interest in supporting research to promote health and health equity, understand how social relationships influence health, improve care delivery, eliminate sexual harassment in biomedical research, and support students and early career researchers, among many other topics. Again, you can find more information on the NIH Grants website. And of course, feel free to reach out to NINR program staff with any questions. In September, the Council approved 2 new Council working groups on important issues related to diversity and inclusion in the work we support and in our research workforce. I'm happy to share updates on these 2 groups. Dr. Cindy Monroe has agreed to co-chair the working group on inclusion in NINR supported studies. And as you can see, we have a membership roster with experience and expertise in both research and community engagement. The first meeting of this working group has been scheduled for February 16th. Dr. Christopher Lee has agreed to co-chair our working group on diversity of the NINR supported scientific workforce. As with our working group on inclusion, we have another membership roster with rich experience in this area. The first meeting for this working group will be held February 15th. Thank you so much to our co-chairs for taking on these important roles, and thank you to everyone who has volunteered to serve on these working groups. I really look forward to hearing from the working groups as they examine these issues. And I'd like to remind everyone that NINR supports diversity supplements to enhance the diversity of the research workforce as well as the entrepreneurial workforce by recruiting and supporting students, postdoctoral fellows, and eligible investigators from diverse backgrounds. This includes those from groups that have been shown to be underrepresented in health-related research or in the small business programs. We encourage all of our funded investigators to consider applying for these supplements to ensure that our work is inclusive of everyone. And I'm excited to share that NINR is expanding our involvement in trans NIH initiatives. Our focus on health equity and commitment to solving pressing health challenges has led to even more opportunities for collaboration across NIH and HHS, and has helped to improve recognition of the importance of nursing research. NINR is now at the table and leading several trans NIH efforts. As part of our involvement with Unite, NINR has a leadership role in a new implementation work group. And we're leading the launch of a new trans NIH group to advance research on social determinants of health in response to grassroots efforts of NIH staff. And as you know, we've been invited to serve in leadership roles on the Climate Change and Health Initiative, the COVID SBE Health Impacts Initiative, the Executive Committee of Helping to End Addiction Long-Term or HEAL Initiative. And since September, we've joined the All of Us Brain Trust, the Executive Committee for Advancing NIH-wide Basic Behavioral and Social Sciences Research, the Maternal Mortality Task Force Advisory Cabinet, and the NIH CMS Joint Council. Our leadership and participation in these activities makes clear that nursing research is being recognized for its vital role in the biomedical research enterprise. And we're also helping to lead the transformative research to address health disparities and advance health equity program of the NIH Common Fund. Thus far, 11 grants have been funded through this program, and additional grants are being considered. You can learn more about the program at the web address on this slide. Note that the FOA for minority serving institutions will be reissued. More information on the publication date will be available, again, at this website as soon as it becomes available. Additionally, a new Common Fund program is in development and will be presented this Thursday at NIH's Council of Council meeting. That is, again, open to the public, and we'll share more information about this potential program on NINR's website when it's available. Speaking of our new possible program on achieving racial equity, NIH is currently hosting listening sessions to improve and inform this effort. Here are the upcoming dates for sessions that may be of interest to you or your colleagues. And again, you can find more information on the web. I also hope that you will join us for the 2022 National Nursing Research Roundtable on March 3rd and 4th. We are co-hosting this event with the Emergency Nurses Association, and we encourage those from across the nursing spectrum to join us. The virtual meeting is From Context to Care, Understanding the Convergence of Social Factors and Emergency Department Care. And it'll bring together individuals representing nursing organizations spanning science, education, and practice to discuss and disseminate research findings related to nursing science and practice to improve individual and population health outcomes. The meeting is open to the public, and you can find more information on our website. In addition to NINR's participation in many NIH initiatives and committees, we're also represented on several HHS-wide initiatives. This includes the HHS Social Determinants of Health Work Group, the Interagency Working Group for the National Healthcare Quality and Disparities Report, and the Interdepartmental Health Equity Collaborative. And we're represented on the Climate Change, Food Systems, and Nutrition Security Working Group of the U.S. Global Change Research Program. HHS is one of 13 member agencies of this congressionally mandated program to coordinate federal research and investments in understanding the forces shaping the global environment, both human and natural, and their impacts on society. Again, I'm so excited to have the perspective of nursing research at these important committees. Since September, I've also had more opportunities to meet with members of Congress, including the co-chairs of the House and Senate Nursing Caucuses and the Democratic Women's Caucus, to discuss current and future health challenges and a new vision for nursing science at NINR. As you know, searches are ongoing for several key leadership positions, and we look forward to updating you on these searches at upcoming meetings. However, I am pleased to report that we do have several new staff to welcome. Please welcome Ms. Anita Ams to NINR. She joined us on December 17th as NINR Chief of Staff. Anita comes to NINR from FDA's Center for Tobacco Products, where she most recently led a knowledge management team that was responsible for supporting the center's tobacco product regulatory review process. Prior to her time at FDA, Anita held multiple research and scientific administrative positions at NCI, most recently as an epidemiologist in NCI's Division of Cancer Control and Population Sciences Applied Research Program. She brings extensive experience leading, managing, and implementing a diverse range of scientific and operations projects at federal agencies and in the academic and private sectors. Her many skills include research project management, strategic planning, procedure development, program analysis, and scientific review. Anita has also contributed extensively to the scientific literature as first author or co-author on 32 publications. She holds a Master's of Public Health degree and a Master's certification in project management from George Washington University. Please also welcome Ms. Frances Bevington to NINR. She joined us October 10th as NINR's Director of Communications. Frances joined us from HHS Office of Disease Prevention and Health Promotion, where she was Director of the Division of Health Promotion and Communications. In this role, she directed the planning and implementation of national health education and outreach activities for Healthy People 2030, the Dietary Guidelines for Americans, the Physical Activity Guidelines for Americans, and the President's Council on Sports, Fitness, and Nutrition. Previously, Frances served as Senior Communications and Marketing Specialist at the National Association of County and City Health Officials, where she developed strategic communication and marketing plans for public health programs and measured progress towards achieving goals and objectives through audience research. She has a Master's in Health Communication from Johns Hopkins University. Please join me in thanking Joanne Kriebel and Eddie Burns, who each acted in this role during our search. Joanne and Eddie have returned to their roles in NINR's Office of Communications and Public Liaison. So thank you both, Joanne and Eddie, for your contributions, and welcome, Frances. We've welcomed several additional staff across the Institute since September. Donna Jones and Alexander Ross are already familiar faces at NINR, Donna as a contractor and Alex as a member of the PHS Commission Corps. We welcome them as official members of the NINR team. And Tim Kearns has joined us on detail from NIDDK. He'll be with us until April, serving as our acting CIO. We also are welcoming Paula Stonebanks, who has joined NINR from her previous position at NICHD, and David Timpane has joined us from the NIH Office of Acquisitions and Logistics Management as our Deputy Executive Officer. So welcome to all of these new staff members. Additionally, NINR is recruiting. We're seeking program officers to initiate, develop, manage, and provide new insights for the Institute's extramural research portfolio. We're specifically interested in expertise aligned with the research lenses identified in the draft framework for the new strategic plan: social determinants of health, health equity, community and population health, prevention and health promotion, and systems and models of care. Now, these positions are filled via NIH's Global Health Science Administrator job announcement. That current job announcement is open until this Thursday, January 27th. Please feel free to reach out to the acting extramural director, Dr. Rebecca Rasuli, also our executive secretary, with questions on this round of our recruitments, as well as for more information on future plans for recruitment. At the end of 2021, we also said goodbye to several retiring staff across the Institute. So please join me in thanking them for their years of service to NINR and wishing them all the best in their retirement. I was honored to recognize one of our retirees with a Lifetime Achievement Award. Doug Hussey retired at the end of 2021 after 45 years of government service. Doug arrived at NINR in 2007 as the chief of the then Office of Science Policy and Public Liaison. Before he came to NINR, Doug served as the first head of policy and communications for the National Center for Complementary and Alternative Medicine, and later in that same role at the National Center for Minority Health and Health Disparities, when both were new centers at NIH. While at NCMHD, he developed the first trans NIH strategic plan for health disparities research. Before his service at NCAM and NCMHD, Doug spent 2 decades in the NIH Office of the Director, in the Office of Legislative Policy and Analysis, serving under 4 NIH directors and handling some of the most sensitive legislative issues of those times. I know that the Council joins me in thanking Doug for his service to NIH, NINR, and to our nation. I'm also pleased to announce that 11 NINR staff received 2021 NIH Director Awards. This recognition was truly indicative of the efforts that NINR took to expand our participation in trans NIH initiatives. So moving on to news from around NIH. I'm sure you're all aware that Dr. Francis Collins stepped down as director at the end of 2021. Along with all the NIH Institute and Center directors, I was honored to participate in Dr. Collins's commemorative farewell, where he received more than 125 video tributes, including from former President Barack Obama, primatologist Jane Goodall, and renowned cellist Yo-Yo Ma. We were fortunate to have had his leadership for so many years, and we're glad that he will still be our colleague overseeing his research lab in the National Human Genome Research Institute. We're also so fortunate that NIH Principal Deputy Director, Dr. Lawrence Tabak, is serving as the acting NIH Director, while the administration selects a nominee for this position. Larry served as NINR Acting Director prior to my appointment and is a past director of the National Institute of Dental and Craniofacial Research. Dr. Tara Schwetz will serve as Acting NIH Principal Deputy Director, while Larry serves as the Acting NIH Director. Tara, as many of you probably recall, also served as Acting NINR Director prior to my appointment. Tara began her NIH career at NINR, where she served as an American Association for the Advancement of Science Fellow. And I'm sure many of you saw that NIH hosted President Biden on the NIH campus in early December for a briefing on the importance of COVID vaccines and booster shots. Those of you following the federal budget process will know that we are still awaiting a fiscal year 22 budget. We're currently operating in a continuing resolution that expires in mid-February. Here you'll see the budget numbers we shared at September Council's meeting. As new information on the fiscal year 22 budget becomes available, we'll share that information with you. And as many of you know, we've been working hard to develop our new strategic plan, and we'll talk more about that soon. As with any strategic plan, NINR will be going through what we believe will be very positive changes in 2022, as we think about how to best implement our new mission and vision. However, we all know that change isn't easy, and we're continually working to help NINR become stronger and even more well-positioned to lead nursing research under our new strategic plan. And as you all know, our nation faces pressing health challenges. We take very seriously our responsibility to best use the resources entrusted to us by the public to move as quickly as we can to solve these challenges, respond to emerging opportunities, and prepare for the future. And finally, I want to congratulate Dr. Paragallo on her retirement, which is just around the corner on January 31st. Naina has had a distinguished career, including deanships at the University of Miami School of Nursing and Health Studies, and most recently, the University of North Carolina at Chapel Hill School of Nursing. She's a nationally and internationally recognized nursing scientist who has specialized in health disparities and culturally competent interventions with minority populations. From 2007 through 2015, she served as the director and principal investigator of the Center of Excellence for Health Disparities Research, the first NIH P50 Center grant awarded to a school of nursing. Her achievements have been recognized throughout her career, including as a member of the Sigma Theta Tau International Nurse Researcher Hall of Fame, as a fellow in the American Academy of Nursing, as one of the 100 most influential leaders of 2012, as selected by Hispanic Business, and as co-chair of the Bipartisan Policy Center's Health Project Workforce Committee. She is past president of the National Association of Hispanic Nurses. She's also served on the National Advisory Committee for the Robert Wood Johnson Foundation Nurse Faculty Scholars Program and the board of directors of IntraHealth International, a global health nonprofit organization that champions the role of health workers. Now, I could go on and on about Naina's many achievements throughout her career. Today, I want to take this opportunity to personally thank Naina. She played a key role in launching my research career many years ago, helping to guide my very first research study and my first published paper for my master's thesis. Her mentorship led to my focus on understanding health practices among Mexican American women and my long-term commitment to research that will ultimately eliminate health disparities. So thank you, Naina, for all your contributions to nursing science and best wishes on your retirement. So thank you all again for everything you've contributed to NINR's accomplishments and for providing your expertise in support of our goals for the years ahead. NIH, NINR, and I value your contributions to our institute. Thank you for bringing your perspectives across so many vital fields of research to NINR. Your guidance on our research and its impact are invaluable. So I'd now like to ask Dr. Lowe to report to us on a special meeting of the National Advisory Environmental Health Sciences Council, which is a council for the National Institute of Environmental Health Sciences. At this meeting, they considered plans for an NIH-wide program of research to explore the health effects of climate change. Dr. Lowe attended on behalf of the NINR Council. Thank you, Dr. Lowe.
As Dr. Zenk shared, I was invited to attend this special session, and I would say it was a real honor to be present and to participate in this session. And I learned a lot about the concept, and I also learned a lot about the process when new concepts are introduced. And so that was just really enlightening and very interesting to me. And so I really appreciate that opportunity. And so I'm just going to give a brief overview and summary of the session. There was a lot presented and it was very dynamic. And so I would encourage you, I provided the link. It was an open session, so the link is here to the meeting, and I would really invite you to view that and to get the full nuances and the very thorough and thoughtfulness of that meeting. Next slide, please. So just to give a little background of where the initiative is grounded in, and so the president has renewed efforts to address climate change and health equity. And so that's where this focus is coming from. And so the budget has been earmarked for $100 million to NIHS for this initiative. And previously from 2011 to 2020, the budget, if I'm recalling correctly, was about 10 million per year. And so this is a significant increase. Next slide, please. So in order to guide and direct this initiative, 7 institute center directors and institutes were invited to become participate in this initiative and help guide and direct it. And the director of NIHS is the executive committee chair. And so also, as you notice, our very own Dr. Zenk from NINR is included in the 7. And so we're very proud of that. And that was really nice to see. Next slide, please. Also, I would mention there's a steering committee that was also formulated and developed, and that was we also had representation there by Dr. Rosenbaum, who is a member of the steering committee for this initiative. So the overall goals for this initiative is to reduce the health threats that are caused by climate change. And this is not only in our country, but around the world. And that was emphasized quite a bit, that, we really need to have a global impact with this initiative. And so in order to achieve these initiatives, risk must be identified and so that the benefits of what we do are in place, and they will help to mitigate and adapt to climate change. And then also infrastructure and workforce development is very key. Partnerships will be critical, and the research that is conducted must have value to achieve the goals. Next slide, please. So what was presented was this strategic framework that was the product of a working group that comprised some very impressive folks from around the country, and it was just really great to hear how they compiled and developed the strategic framework. And here is a list of all of the types of information and inputs that were included in order to develop this strategic framework. And it's so impressive that it was done in such a kind of a short period of time. And so this was really impressive that they were able to accomplish so much in this time period. Next slide, please. So the strategic framework has 4 core elements and presented in this wheel. And as you see, health effects research, health equity, intervention science, training and capacity building. And then the cogs of the wheel are the supporting areas of science that will be supporting to achieve these 4 core elements. So in the next slide, the specific areas, again, the health effects research. This is where the science will be conducted in order to investigate what the influences of climate change are on health outcomes. Health equity was talked about quite a bit, and which was good to see that there are marginalized populations that must be addressed because of their vulnerability and risk to climate change in regards to health. In order to have intervention research, this must be done from a perspective that it will provide evidence base for developing implementation strategies. And then the training and capacity building is necessary, a component, and then here are the list of the supporting areas of science. Next slide, please. So in conclusion, of course, we think about, okay, what's going to happen with the funding and how is that going to be appropriated? There was much discussion around that $100 million, although it seems a lot, may not be a lot in when you look at all the things that need to be done, so that the real emphasis should be on that the funding would act and serve as a catalyst, so that there's NIH-wide commitment to and involvement in order to address these this initiative. And so here are the ways and that this funding may act as a catalyst. One of the real kind of more discussed areas was that there would be centers of excellence, and that out of the centers of excellence would come more research, and that would serve as that catapulting type of activity around being able to achieve the goals and objectives. Also, some of the discussion referred to how current centers of excellence would possibly be able to apply and receive funding for administrative supplements, where they could now have a focus on climate change and health. So that was really good to see. So that was basically the summary of it. Again, there was just very, very thoughtful information, robust discussion, and I would encourage you to listen to that recorded session and to get the full gist of everything that was discussed. But again, it was a real honor and privilege to have attended. Thank you very much.
Thank you, Dr. Lowe, for representing council at that council meeting of NIHS and for that report. So I'd now like to ask Dr. Fitzpatrick. We've asked her to lead the discussion of council on this topic. Dr. Fitzpatrick.
Okay, sorry, I was muted. Thank you, Dr. Lowe, for that presentation. I was curious if you could comment a little bit more on the types of research that might be of interest. I mean, do you think it's more intervention work, or there's still a lot we don't know about mechanisms and associations and causality?
Correct. I think it seems that, and there was discussion around how intervention research would happen, but first there needs to be the infrastructure support, and then there needs to be workforce and teams, and that was discussed quite a bit, and that there would be transdisciplinary teams, and then how really will that look like, and how will that be developed? Transdisciplinary work is interesting. It's not easy to do, and there is quite a bit of guidance that probably needs to happen in order to develop what teams would look like. A lot of emphasis was focused also on how across the NIH ecosystem would be involved, and then also other outside organizations and other agencies within the government, but also an emphasis on global. So I think it looks like that the previous work that has been done, meaning the research that has been done regarding climate change and impact on health has been really descriptive. So the intervention approaches have not really been, the science is not quite there. So it's sort of going to be, I think, open to, or there's going to be development around how that would look and what kinds of interventions would happen. So for example, I did, if I can just share with you, some of the examples would be RCTs with working space and hydration among, like, for elderly and for pregnant moms, and especially in times of climate change in areas. Some of the other types of work is how do you mitigate depression where there's been climate change, developing measures of longitudinal clinical change in BIPOC populations due to climate change. So there's lots of possibilities, and that's what's exciting about this. I think definitely as nurse scientists, we have some really good possibilities and opportunities to be able to address, and especially health disparity and health equity issues that are among the populations that we work with. Dr. Stone, do you have a question?
I did. Thank you so much for the presentation, Dr. Lowe. I was wondering, so they didn't talk, I could sort of imagine things being regional. I think of Katrina and what would happen for flooding or something like this, because I don't think that this money is to combat climate change, but combat our responses to climate change and preventing it. But, so I just wanted, what you just went over helped me think about it a little bit, but I was just sort of thinking, are they thinking about regional areas for certain problems or not?
Right, so that's a good question. Thank you for that. Some of the comments from the advisory council of NIHS to the working group that created and developed the strategic framework, from all the input and data they gathered, some of that, what they felt like might have been minimalized and should probably have some attention to it is the preparedness, for the climate change events. And so they did not feel like that was as emphasized, and that may need to be a component. And I think that might be something that you're, in response to your question. So preparedness, and it does seem like the focus was more on mitigating the impact and the impact of climate change on health issues and what that looks like and what can be done. And so that prevention quite didn't get tweaked out as much. And I think that's an area that will still be considered. Thank you. Dr. Santan?
Thank you. Sorry, I was hungry before lunchtime. I just wanted to mention that it seems like this is a great opportunity also to work with kind of policy research, that there's so much policy interest in the Senate and the House in terms of alleviating some of the effects of climate change on health, and also being able to predict, now that we know that there's a wildfire season in a lot of places, and and droughts and heat events, that there's a lot of policy interest in trying to figure out, do we give everyone air conditioners in places that weren't as hot before? But that we can not only, we're used to changing policy by first doing a pilot and then an efficacy trial and then effectiveness, and then we change policy. But I think there's a chance here to be a little more iterative, where Congress tries something out, we research it, and go back and forth that way as well.
Thank you for that. And that's a good point. One of the responses from one of the council members of NIHS did mention that they felt that was also a component that didn't come across real strongly, but would need to definitely be considered, because without policies, as we know, the impact of what could be done is, and also there were mentioned the gatekeepers, or what that looks like. And so it kind of reminded me of sort of probably the implementation science area might really help with that focus. And so that was very noted in some of the responses. Thank you. Dr. Johnson?
Hi, really great summary and presentation. I'm very excited about the work. The cynical side of me is wondering about whether there are discussions about how to insulate this work from political pressures or special interest groups. And I know there are systems in place, but particularly with this topic, I don't know if that, and maybe this has been worked out in the Institute in the past, but when I hear about this great progress, I also have a side of me that's concerned about keeping it data-driven, science-driven, and free from special interests. And I have no idea whether that's part of the purview of the group that you were with.
Thank you. I'm so impressed with the questions, if I could just note, because all of these areas were noted by the and brought to the conversation by the council members, and so that was it's really impressive that you're noting these areas also. And so that was an area that was of concern. One of the responses noted that there would be it would be key to have attention paid to correct information, and especially publicly as this initiative moves forward and gets announced, and I think they were reflecting on some of the recent things about the pandemic that we're in, and so that they felt like that, just as you mentioned, could have an influence on how this develops, and this initiative, and how it really is accepted and moves forward. But it was really mentioned that it's really about messaging and information, and there would need to be at least a special focus to make sure that was really had vigilance. And so thank you for that question. Anything else? Okay.
Great. Thank you, Dr. Lowe and Dr. Fitzpatrick. This was really helpful for all of us at NINR. There's several of us participating in this initiative on various committees as it's planned, as it's developed, and then eventually we hope as it's rolled out. And so we can take your feedback and your ideas back to those groups as that work moves forward, and we look forward to future conversations on this area and about this initiative, hopefully as we move forward. So thank you, Dr. Lowe, again. With that, our next item of business is to consider a mandatory report on participant inclusion, and I'll turn it over to Dr. Rasooli.
Thank you very much. I'm going to share my screen now and show you a few slides. So this is a mandatory report, as Shannon pointed out. Every 3 years, NIH is required to report to Congress on enrollment of participants in clinical research, broken down by gender, race, and ethnicity. And that's in order to monitor adherence to the NIH policy on the inclusion of women and minorities in research. The 21st Century Cures Act changed the frequency of this reporting to triennial, meaning that we share data from the past 3 years, 2019, 2020, and 2021. And each NIH institute and center submits a report to NIH centrally, and then a single report is compiled and submitted to Congress. The latest report is what I'm going to show you today. And it includes data from the previous report, the report on enrollment in 2016 through 2018, and that was presented to you in 2019 at our council meeting in May. These are the most recent data that are available, and as you can see on this first chart, it's broken down by sex and gender for the indicated years. And one thing that I think is very positive is that over these 6 years, that the proportion of participants who are female has declined quite significantly. This table shows the enrollment by year by race. And here, I think maybe the most notable takeaway is that African Americans, Blacks, their enrollment has varied between 17% and 30% over the 6-year period, which is in every year substantially higher than the representation of Blacks or African Americans in the US population, which is at about 13%. And this is especially good news because we know that African Americans have higher morbidity and mortality for a large number of health conditions. Another nice bit of data shown here is that the participation of individuals who are American Indians or Alaskan Natives has risen actually almost tenfold as a proportion of our clinical research participants. Overall, minority enrollment has varied from about 26.5% to 28% over the 6 years, meaning it's relatively constant. And finally, in this last slide, just showing you the enrollment by ethnicity over the past 6 years, there has been some growth of enrollment of Latinx participants from about 7 to about 10 or 11%, but these individuals are still underrepresented in NINR extramural research relative to their abundance in the US population and their burden of health disparities. And so that concludes my presentation of this report. And what I wanted to do now was to ask you if you would like to comment at all on these data, or if you have any concerns about any of the data that we've shown you today. Dr. Paragon-Latano?
Yeah, I really
Let's see, are there other comments?
So Rebecca, I have a comment, and I want to thank you for highlighting that those data for us. I'm really interested in what strategies you all have been employing of late to increase those numbers that we've seen when it comes to those who identify as Latinx, to maintain the African American inclusion, and then of course the Native American. But then I did see on the flip side the Asian American numbers decreasing. So I wanted to get more insight into what you have done to increase and sustain for those groups, and what's happened there with the Asian American data.
So the first and most important thing that we've done is decided that we're going to think about this in a serious and systematic way. And I just wanted to again call attention to the council working group on inclusion that's going to start meeting in a few weeks to think about this systematically. Shannon discussed our enrollment data in May at the council, which is what the impetus for forming these council working groups. And also, I would say that the other thing that we've done, and you'll see this in the discussion of the strategic plan, is that we're putting a more explicit focus on the study of health disparities, which will surely increase the number of research participants from traditionally underrepresented groups. Shannon, did you have any other comments?
I think that's a good start. I mean, we recognize that we want to do better in these areas, and so we have been talking about this over the past year. And I think all of NINR is very excited about the working groups and what recommendations will be brought to the table about looking at the entire funding process in terms of how we can ensure that we have more inclusion in our studies. So I think this is really important to us. We are very grateful for everyone who's volunteered to serve on those working groups. And we look forward to all ideas in terms of how to improve inclusion in our studies.
I apologize, I got dropped off by the computer.
Did you have some comments?
There's something wrong with my system.
But we hear you very well.
You can hear me. Well, I was making the comment that it was disappointing, the numbers, and what are we doing to ensure the representation of Latinos in the studies. I mean, right. Kicked out of the computer, and you can see I'm frozen, so I don't know what to do right now to keep me connected here.
But thank you for your comments, echoing those of Professor Dawes and echoing Shannon's comments. And as we pointed out, as you were pointing out, we do need to do better, and we need to think about this systematically, and then move forward in ways where we can see demonstrable results.
This is Pat. I just had one comment, and it's because of my own confusion, of which I figured out, you can see in the chat box. But at first I thought the data were from who's getting funded. And then I realized these are the subjects. And so really, I think that it is two-pronged of having a workforce that is diverse and reflects. So, who's getting funded, that part and having some data. I don't know how we have those data, or as well as, of course, having participants in the research. But I think, we need a diverse scientists to lead these studies. And so it's sort of a two-pronged approach.
Really excellent. Other comments?
So I am appreciative of these data as the working group begins to form and takes up the charge of really looking at the inclusion data, to have actual data about how the inclusion is at the moment and what it's been traditionally, I think will be of great value to the working group. So thank you.
Dr. Lowe?
Yes, I would echo Dr. Stone's comments about the workforce and especially about the scientists and who they are. And I'm glad to see that studies among Indigenous, Native Americans, Alaska Natives, Native Hawaiians may have been increased. I am passionate about having nurse scientists who are Indigenous and Native be prepared to be able to do the work among our communities. As a Native American, I know I've lived in community, I have lived among and worked among with my own research and know the value of how nurses are perceived within our communities, and our communities value nurses, they trust nurses. And so I think we are really at a disadvantage in pursuing research among and increasing research among Native communities, since we have such few Native and Indigenous nurse scientists. So I think that's a real area that needs to be focused on. Thank you.
Thank you. Dr. Atkins?
Yeah, I think, thank you for the presentation. And I think this actually dovetails just with what Dr. Lowe mentioned about a lot of communities that we're missing, and the importance of us being able to disentangle race and class and think about place in the same way we think about tribal lands and the Rust Belt and the Mississippi Delta and our non-metropolitan communities that are sometimes outside, or in a lot of ways invisible to us because they're not where universities are, and because they're not where universities are, they're not where researchers are. And so I think we have to make special effort really to, even as we think about race and ethnicity, but also thinking about these places that we're missing, these places that just are invisible to our researchers and invisible to our research. And so it's something that I'll probably keep banging that drum a lot in my time on this council, because I just think it's so important. And I know I talked Shannon's ear off about it already, but I'll keep coming back to that. So.
And
I'll just jump in and say we welcome that, Bob. Just keep beating that drum and keep coming back to us. Thank you. We appreciate your perspective on that.
And I should also out myself. I'm an enrolled member of the Nashville Wampanoag tribe as well. So that really resonates with me as well, thinking about our tribal lands and our tribal peoples.
And Rebecca, my understanding is that the group that is looking at scientific workforce is a work group that is meeting concurrently with when the inclusion task force, subject inclusion task force is working. So there is a intent to address both prongs of this problem. Is that not correct?
Absolutely. And your comments and comments of your colleagues here on the council emphasize that the problems are not really separable, that one influences the other. And so it's very important for these groups to meet concurrently and then to have the kinds of interactions and the synergy that will lead, again, to demonstrable improvements. Dr. Lee?
Yeah, thank you. I was just going to mention to our colleagues who are new to council that data on self-reported race and ethnicity among investigators was presented at a prior meeting. So we'll have to go back and take a look at those notes, but highlighting the same issues. And we may think initially of these task forces as working separately, but Dr. Monroe and I can certainly work together to make sure that our efforts are harmonized for the benefit of all.
Thank you. Thank you so much. Really excellent.
We did, Chris, right, share in September some data, just a starter look at diversity of the scientific workforce that we're funding currently, as well as differences in success rate. So as both of these working groups get started, we'll look forward to hearing what data, what information will be useful to inform the work, and be gathering whatever data we're allowed to share with those groups, and, you know, as appropriate, those groups can share with council as well. So thank you.
All right, so I just one more time to circle back, noting all your important comments and thanking you for them. Are there any concerns about submitting these data from NINR to NIH centrally? I'll take that as concurrence. So then I also wanted to ask you to return here at 1 o'clock after we take a break. And we'll be joined by Dr. Lange then of NCCIH with a really interesting presentation. So we'll see you at 1. Thank you so much.
Welcome back, everyone. I am so pleased to introduce our next speaker, my colleague, Dr. Hélène Langevin. Dr. Langevin was sworn in as Director of the National Center for Complementary and Integrative Health on November 26th, 2018. As NCCIH Director, Dr. Langevin oversees the federal government's lead agency for scientific research on the diverse medical and healthcare systems, practices, and products that are not generally considered part of conventional medicine. NCCIH funds and conducts research to help answer important scientific and public health questions about natural products, mind and body practices, pain management, and whole person health. The center also coordinates and collaborates with other research institutes and federal government programs on research into complementary and integrative health. I have so appreciated Hélène's guidance, support, and friendship since I arrived at NIH, and I look forward to continuing to expand collaborations between NINR and NCCIH. Today, Dr. Langevin will be speaking with us about the NIH Pragmatic Trials Collaboratory. Welcome, Hélène.
She seems to have dropped off in the last moment.
I see that, and I'm looking under the attendees. She's not there.
Let's see.
Sure, she'll hop back on. Must have been a technical issue. Oh, okay. Great. She'll be with us in a moment, it looks like. Hi, Hélène. Welcome.
I disappeared, but then when I came back in, I was not in the, I was just in the regular webinar.
Well, we're glad we solved that. Always.
It happens.
Yes, always. Yeah, bad mood in terms of the internet, indeed.
Yeah. No problem.
Welcome. We're so glad to have you with us. Are you going to be sharing your screen, or would it help if?
Yeah, well, that's right. I seem to be. I just sent my presentation to Samantha, but I'll try sharing. But if there's any problems, then you want me to get started?
Yeah, yes, if you're ready, or we can wait another moment.
I missed a minute. I don't know if you've already, introduced me and stuff.
Oh, you missed that. Okay, I didn't know when you dropped off. I did do a very nice introduction.
We're gonna wing it. Okay, I'll share my screen and I'll just get started. Okay, wonderful. All right, there we go. Can you see this?
Yes.
All right, we're good. All right, excellent. Well, I really want to, thank you to Shannon and to NINR for giving me the opportunity to talk about the NIH Collaboratory, because it's a very exciting trans-NIH that NCCIH and NIA, the National Institute on Aging, have been co-leading now for the last 10 years. And I want to, just give you a little sense of the history of the collaboratory, and also why it's a really important resource for NIH institutes such as NCCIH and NINR that share many common interests in clinical research. So first, I want to spend a little bit just to give you a sense of the name. What is the NIH Collaboratory? What does that mean? Original name of the collaboratory back in its inception was called the NIH Healthcare Systems Research Collaboratory. So you can imagine that's a little bit of a mouthful, and it gradually people started calling it the collaboratory. But the problem was that over the years, there were other collaboratories that got started. For example, the Impact Collaboratory at NIA, which is about clinical research on projects related to dementia. Also, we have a pain management collaboratory in the collaboration between the NCCIH and the Department of Defense and the VA on pain. So this year is a 10-year anniversary of the collaboratory, and it's also marked its transition from the Common Fund, and I'll tell you more about that in a second. But we thought that this would be a really great opportunity for rebranding the collaboratory and changing the name. So it's now called the NIH Pragmatic Trial Collaboratory. And I'll explain what that means. But the idea is that it's not about any specific disease or condition. Like, it's not about something specific like pain or like dementia, but it's really about the pragmatic trials and really kind of facilitating and augmenting, the capability of pragmatic trials. So going back in time a little bit, back in 2012, the original Healthcare Systems Research Collaborative was started, and this was an initiative that was part of the Common Fund, and I'll tell you in a minute what the Common Fund is. But the mission of the original collaboratory was to strengthen the national capacity to implement cost-effective, large-scale research studies that engage healthcare delivery organizations. That's really, really important, as research partners. And you can see here on the right all the institutes and centers that were part of the original collaboratory back in 2012. And you can see that NINR is there. And so what is the Common Fund and how does that work? So the Common Fund is a component of the NIH budget that is managed by the Division of Program Coordination, Planning, and Strategic Coordination. We officially call it DPCPC, which is kind of a funny name. And this is within the office of the NIH Director, so Dr. Collins at the time. And what the Common Fund does is it really is aimed at addressing emerging scientific big challenges that no single NIH institute or center can address on their own, but is a priority for NIH as a whole and can really benefit research in NIH as a whole. And the common fund projects are typically, so this is not so as you can see, this is funded outside of individual institutes or centers. And the goal are typically what they call short term. So typically 10 years. They're not projects that go on infinitely. And these are goal-driven strategic investments in programs that have the potential to be transformative and to really sort of catalyze, growth of research, and also importantly are cross-cutting. So they have interests in multiple institutes and centers. So initially in 2012, the Healthcare Systems Research Collaborative was fully supported by the Common Fund. Everything was paid by the Common Fund. And then there was a transition phase between 2017 to 2019, and where the Common Fund continued to support a good part of it, but the NIH institutes and centers were asked to chip in. And the reason for that is because the hope for these Common Fund projects is that they would have an extended life beyond the 10 years of funding of the Common Fund. And what typically happens when the projects are successful, which is not always the case, but when a Common Fund project is successful, there has been kind of garnered enough demonstration of benefit of these projects and enough interest among the institutes and centers that they want to continue this project, and they collaboratively come up with funds to continue the project on their own outside of the Common Fund. So there's typically kind of a weaning period, so to speak, so that and that's what's happened during the from 2017 to 2021, but starting from 2017 to 2019, there was a little bit more contribution from the institutes towards the funding of the projects. And then what happened in 2019 is the HEAL initiative happened. And the HEAL initiative was a large program that was mandated by Congress that was appropriated $500 million a year for research on pain and opioid addiction to address the opioid crisis. And so that part of the HEAL initiative funded a number of pragmatic trials on pain and opioid use disorder that were kind of grafted onto the Common Fund. This was just additional funds provided by the HEAL initiative. So there were additional projects that were called PRISM, which means pragmatic and implementation trials to reduce opioid prescribing. Then in 2022, so now, the program is now graduated from the Common Fund. So the program is now fully supported by NIH institutes and centers, and the HEAL initiative is continuing to support it. The Common Fund is now phasing out. So essentially, as part of this graduation and rebranding and rethinking of the mission of the Common Fund, of the collaboratory, Pragmatic Trials Collaboratory. The emphasis now is on, and you'll see it's almost very similar to what it was before, but slightly different, large, efficient studies conducted in the real world that provide evidence for adoption of an intervention into clinical practice. So there's now a little bit more of an emphasis, not just on the efficacy, but on actual implementation, because we know that this is a barrier. A lot of times there are interventions that we know are effective and that benefit patients, but they are not adopted into the healthcare settings. And there's a lot of reasons for that. And so implementation, kind of the bridge between effectiveness studies, pragmatic studies of the effectiveness of an intervention to its implementation and eventual dissemination. So that's become now a new emphasis of the Pragmatic Trials Collaboratory. And so as you can see, there's a range, right, of types of studies that are supported. And I talked about the Common Fund addressing big challenges, right? And some of the big challenges is really studying designs of studies that really address the concerns and of the stakeholders, meaning the healthcare systems, the patients, the clinicians, right? interventions that can be studied what we call in the real world, meaning not in some artificial research setting, but really that are interventions that are incorporated into the routine clinical workflow and studied as such, right? Data, for example, collected through electronic health records. So really kind of embedding the research into the healthcare. Studying diverse study populations, extremely important, and also making sure that the outcomes are important to decision makers, the stakeholders that decide, whether an intervention is going to be adopted or covered by insurance. So here are the components of the collaboratory. This is how the collaboratory works. There's a collaborative coordinating center, which is right now located at Duke University, and this has been periodically recompeted. And the coordinating center kind of essentially coordinates, right? There's demonstration projects that are all pragmatic trials. There's also the collaboratory cores and working groups that assist, that help in helping it with the design of the projects, with all kinds of expertise regarding the statistical analyses, the making sure that the projects are appropriately powered, all the things that make, and also recruitment challenges. They were particularly important during COVID, making sure that projects were able to stay afloat amid challenges, like things happen, right? There's a steering committee that guides the whole enterprise, and also very importantly is a learning component to this, what's called a learning healthcare system and knowledge repository, and I'll talk to you a little bit more about that. So what about these core working groups? So there's a biostatistics and study design group, electronic health records, healthcare systems interactions, patient-centered outcomes, ethics, and regulatory. And these working groups are really, really important. They have proven very key in making sure that the studies that are supported by the collaboratory are successful. There's nothing worse than starting a large-scale clinical trial and then running into problems, and then the trial fails. And of course, it's a big loss for everyone, right? Big loss of money, time, expertise, et cetera. So having this expertise, not only from the coordinating center, but also the collective expertise of all the investigators who do these trials, essentially form like a family, essentially. They can share, problems that they're facing, solutions, so that this combined expertise can continue to grow. And it provides, of course, this administrative framework for the program. So now what about the pragmatic trial demonstration projects? So there are periodically RFAs, or requests for applications, for these different, what we call milestone-driven awards. And these awards are phased awards. So there's 1 year planning phase, which we call the UG3, followed by a 4-year implementation phase, during which the clinical trial actually happens. The trials are required to participate, to involve at least 3 partnering healthcare systems. And there's also a requirement that these pragmatic trials are actually embedded in the healthcare systems to address questions of major public health importance. So far, the collaboratory has funded 21 pragmatic clinical trials involving 15 institutes, centers, and offices at NIH. Variety of very diverse clinical settings, including more than 1,100 clinical sites. And you can see on the map here involving the large majority of the US geographically, 20 different healthcare systems, and almost 1 million participants. So you can see it's been quite very successful in terms of really kind of making things happen. You can see here, I was talking about the transition from the UG3 to the UH3. So far, it's been very successful. So only one trial, you see up here, did not make it and essentially stopped after the UG3 phase. One project here, this impact low back pain, is still in the pilot phase and has not transitioned. And so far, all the other ones have transitioned. Now, this is a little different. Like sometimes we'll fund phase awards that are more exploratory in nature. For example, we have at NCCIH, we have an R61, R33 type of projects where you have a pilot, a planning phase or a sort of a preliminary phase, and then transition over and to the full, implementation phase. But a lot of times, some of these types of transitions or awards are built so that they're high-risk awards, and you expect a certain amount of failure, right? It's a little bit more like in business where, a certain number of, you fund a certain number of projects, and you expect that a lot of them are going to fail, but some of them are going to continue. This is different here. The expectations is that these trials are going to be successful, and the reason for that is because of the tremendous support given by the structure of the collaboratory. So I'm showing here, these are all the acronyms, all the wonderful acronyms. Every one of these trials has a cute name. And you can see those that are highlighted in red are those where I illustrated where NINR provided project scientists for all of these projects. So I'm just going to run through them really quickly. So this particular one here called ACP Peace, which is a cluster trial testing whether clinician communication skill training and patient video decisions aid with increased advanced care plan completion in patients with advanced cancer. So this is one. This one proven on the effectiveness of advanced care planning videos shown in nursing homes in 2 large care systems. Here's one about testing the availability of a telehealth strategy that provides a brief pain teleconsult along with phone-based physical therapy. This one is the feasibility and effectiveness of adding TENS to treatment of patients with fibromyalgia in real-world physical therapy practice settings. And so those were all the projects that I highlighted were those that NINR contributed to. Now, a few words about this sort of knowledge repository and learning healthcare system function of the collaboratory. One of the very important functions of the collaboratory is really disseminating the information that we learn through conducting these clinical trials. And there's something called the Living Textbook Knowledge Repository, which is online, and it's on the website you can see here, of the collaboratory. And you can see that there's a lot of traffic on this textbook. You can see that all the page views, with this sessions and users, etc. And this is a really wonderful database for investigators throughout the world to learn how to best conduct a clinical trial. A lot of experience goes into this. Grand rounds, very, very important. We've had a tremendously successful what we call the Rethinking Clinical Trials Grand Rounds. 411 grand rounds. That is, I can't tell you how good these rounds are. They're very well attended, and overall 250 attendees but some of them we've had over several thousand. Some of the grand rounds was really quite remarkable, and the opportunity for investigators to present their findings to an audience of very sophisticated trialists who really they're very engaging discussions. You can see here publications, a total of 223 so far since the start. Publications since from both the coordinating centers, the cores, as well as the demonstration projects. Importantly, there's really an effort that is ongoing to strengthen what we call a distributed research network, such that investigators can collaborate in the use of electronic health data while safeguarding the protected health information. So what the structure of this distributed network allows is that investigators can share data obtained from electronic health records through this sort of distributed research network. So this is, again, an area that is evolving very quickly about data sharing, and the collaboratory is really kind of at the forefront of all of these important issues surrounding ethics and protection, et cetera, safeguards. So what about what's going to happen after the transition from the Common Fund, which is actually happening pretty much as we speak? So just to sort of recapitulate what has happened. So this was the situation at the beginning, right, where you had the Common Fund, the Coordinating Center, the core working groups, and a small number of demonstration projects. And then the oversight was this advisory panel, steering committees, and then you have all the institutes and centers. So the Common Fund was then only started funding the Coordinating Center, with the institutes kind of starting to take over, then the HEAL initiative, and now you can see the Common Fund is gone and the number of demonstration projects is increasing. So what was the process for this? So we recompeted the Coordinating Center, which is ongoing right now. So in terms of the applications are still under review. We've reissued some RFAs for the EU24 already for the 6-year duration. So we're going to be, the plan here is that the institutes and centers that are participating now will each contribute $200,000 per year for up to 2 pragmatic or implementation trials. We did make a concession, to the smaller ICs, including an NCCIH, and well, NCCIH is a little bit of a special case because we fund a larger proportion of the coordinating center because we're one of the 2 leading ICs. But institutes like NINR can contribute less than 200, so 100 per year for 1 pragmatic or implementation trial. If they want to fund more, they can, but this is the minimum that's required. And then the offices, for example, the Office of Behavioral and Social Sciences contributes 75 to 150 per year. And then there's a memorandum of understanding with each of the institutes and centers to sort of going forward. The RFAs were reissued for the demonstration projects. And so each demonstration project is up to 50K, $500,000 direct costs for the UG3 phase, and up to $1 million in direct costs for the UH3 for up to 4 years. And these are pretty large clinical trials. And there's obviously the institutes and centers can pursue co-funding from other institutes and centers, just like we do with any other project. We really encourage people to sort of reach across the different institutes and see if there are projects that are of interest to more than one institute or center. So basically, this is kind of the story of the transition, and this is where we are right now. Dr. Hodis and I are actually going to present this next week to what we call the Council of Councils, which is the council such as this, but for the Common Fund. And we just redid the rebranding at the beginning of January. So, this is happening right now. And as part of this, so I'm showing you here now the institutes that have committed to being part of this new phase of the Common Fund. So we have NCCIH and NIA. These are the 2 leading institutes of center. We have National Cancer Institute. We have the National Heart, Lung, and Blood Institute. Allergy and Infectious Diseases. Arthritis, Musculoskeletal Skin Diseases, NIAMS. Minority Health and Health Disparities, NINR. And the Office of Behavioral and Social Sciences Research, as well as the Office of Disease Prevention. So, as I indicated before, the new areas of focus are in implementation science, and that study strategies for implementing evidence-based interventions into healthcare delivery. And we also added an additional area of interest in focus on health disparities in healthcare delivery. And so we feel that this is well aligned with many different institutes and centers. And I've listed here some of the areas of interest in NINR going forward, from going from health equity, social determinants of health, population, community health, prevention, health promotion, and systems and models of care. These are all areas that are very, well aligned with the new and the existing and new directions of the collaboratory. So there's a lot of like-minded institutes at NIH that really share these priorities, but especially the institutes that are represented here, I think are a very good example of the kind of cross-cutting research that could really be benefited from the expertise of the collaboratory. So in summary, basically the collaboratory has successfully transitioned from the Common Fund to Institutes and Centers support, and we're very grateful that NINR has joined the family of institutes and centers that are supporting the collaboratory. Over 90% of the projects to date have transitioned, so a very good yield. This is really a testament to the success of this program. There's been an unparalleled impact of the demonstration projects on knowledge and practice, as witnessed by the community of researchers that are really thriving around the opportunities for dissemination of the knowledge, the grand rounds, the living textbook, etc. And then the facilitation of rigorous, large, efficient studies in the real world that provide evidence for adoption of an intervention in the clinical practice. I cannot stress how important this is as we really want to move the needle on effective research that really changes healthcare, that really changes how healthcare is practiced, and that where you can see that the research is not just published and just sitting on a shelf somewhere, that really makes a difference in the lives of people. So I'm going to stop here, and I'd be happy to take any questions.
Thank you so much, Ellen. It's so exciting. It's great to have it moving out of Common Fund and being adopted across NIH. So thank you for your leadership. We already have questions. I know Dr. Stone and Monroe were also prepared to lead discussions. So I'll let Dr. Stone and Monroe facilitate from here.
I want to thank you, Dr. Lejvan. Did I say that right? Lejvan?
Yes.
What a great presentation. And I truly agree with you that it really is very synergistic with the new NINR strategic plan. Some of the things that I think are that I thought about was one, in the planning phase, are most all of the interventions really already hooked up with healthcare systems? Because there's some settings that their healthcare systems, you don't want to just do it in, like, I'm thinking of a nursing home chain. I don't want to just do it with the nursing home chains. There's a lot of different types of healthcare systems. And I was very pleased that what the research that you presented was across systems, not just acute care. But is it really that you need to be connected with systems, or just being able to enroll many of these, diverse settings?
Very good question. So we're really emphasizing that there needs to be a number of different sort of sites, right? We don't want all the research to be done in one place. Sure. That's an important thing so that it's generalizable. In terms of the healthcare systems, you're talking about like whether nursing homes, for example, would be considered a healthcare system?
I know that you did the one in two nursing home healthcare systems. So those are nursing home chains. They can be for profit or not for profit, and so many, and it's true with home health also, sort of similar things, that some of these healthcare systems, I guess, do you really need to be hooked up with the healthcare system, or is it just having access to a large amount?
You really need to be hooked up with the healthcare system, but I guess the question is, what's the definition of a healthcare system? Maybe that's where there could be some conversation. Yeah. Right? I hear you, and I think this is important. These are the kinds of things that what is the definition of a healthcare system? There are a lot of different. For example, if somebody was to propose something with, for example, in schools, right? nurses in schools. Is that a healthcare system? Well, I don't know. I'm not saying that this would or wouldn't be, but a lot of children get healthcare from their school nurses, right? Sure. To me, that would be a very important question to figure out is to whether this type of research, if you decided that you wanted to do a project on school nurse delivered care, is that considered a healthcare system? And if so, how would you do it? And I think that where the collaboratory can be really helpful here is in debugging. How do you do research like this? It's really meant to be very pragmatic. What are the problems that people face in real life when they try to do research that's innovative and that is really kind of going to move the needle on something, right? There's always things that you don't think about, like, oh no, how do I do this? And just to make sure that people don't waste their time, get the experts in there who haven't done exactly this problem, but they've solved a lot of other similarly gnarly problems, in getting things to work. For example, in different types of healthcare delivery systems that have their own challenges, right? Yeah. So it's a very good question, and I'm not sure I can't really answer it yes or no, but I think this is the kind of thing that could be discussed for sure.
No, absolutely, and I find it very exciting. I think Sarah has a question, or Cindy, did you want to ask something?
Oh, sorry.
Yeah, I was just going to ask about the opportunity, as you talked about the innovative methods and that kind of thing, the opportunity for training of new scientists. To what extent is there a connection with the training mission and with the development of new scientific voices, particularly those who might have new and exciting innovative perspectives?
Yeah, it does not issue training grants per se, like, funding for, students or postdocs or, specifically. But there is, through the educational piece, like say, for example, there would be a research group that would have trainees. There is an amazing opportunity for learning. So in terms of just kind of being part of the figuring out how to do the trial, essentially, right? So I would say it does not have a training component, but I can't think of a better experience for a trainee than to be involved in a clinical trial that participates in the collaboratory. I think they really would learn how to do it right.
So might there be some emphasis in the future on bolstering the new scientific workforce, which we hope will enhance the diversity of our scientific workforce?
Yeah, we could talk about that. I mean, right now it's not emphasized in terms of funding. It doesn't really fund individuals. It funds the trial, right? And then but like every research at NIH that NIH funds, there's a tremendous emphasis on diversity and inclusion, and also of encouraging investigators that are of underserved backgrounds, for example. So any grant that gets funded by NIH gets scrutinized to that extent that we really encourage that trainees, for example, or any investigator that's on a grant that really is we look at the diversity, basically. It's very important.
Can I ask my question? Thank you. So I essentially have the same question as Pat, but a slightly different way, which is that we know that the care people receive in however systems are usually defined is only a small part of health. And so, there's so much about where people live and work and play and all of that. And so I think that having such a big emphasis on healthcare systems is great, but that's just a part of the puzzle. And so I wonder if there are ways that we can creatively work together, as you mentioned, school health or other kinds of ways that are not necessarily a hospital or a nursing home or a chain of clinics that could fit. I think that would.
I think it's up to NINR to bring it to the table, right? And I think this is an area where there's room for growth and you know, it's this is the kind of thing that if there's a proposal that is brought to the collaboratory and discussed, and if this is an area that has never been breached before, it can be talked about and just see whether it fits or not. You know, there's no barrier to innovation really. It shouldn't be.
There's so much inequity into who has access to the current healthcare systems that it doesn't make, it seems a little bit like, trading around the chairs on the deck of the Titanic. I mean, that's overstating it, but so thank you for that.
Yeah, I again, it's not a matter of, I wouldn't think that there's guardrails around this, right? It's the other way around. This is the spirit of the collaboratory is to really want to expand the reach of what a clinical trial can do, right? So it wouldn't make sense to just say, this is what you can and cannot do. What we don't want, and this is clear, is what we don't want is trials that are not generalizable, that would only be done in a very narrow segment, only in one place, one environment with a very homogeneous population, with a very standardized treatment, which is not the real world. So the whole point of this is that we want it to be the real world. So by definition, it's more messy, it's more complex, it's less well-defined. That's the whole spirit of the collaboratory.
Okay. Thank you.
And do you see what I mean? So yeah, I see your concern, that there might be, but if you think about it that way, it does make sense, right? That's what we're trying to do.
Thank you. Daniel?
Hi there. So yes, I actually was going to state the same thing that Sarah and Cindy had mentioned about how do you define healthcare, right? Given that the NINR is really interested in, moving towards or moving further upstream, addressing those social drivers of health inequities and looking at how we can really sort of stretch that umbrella, if you will, of inclusivity. I'm really interested in going beyond a little bit more than what Sarah and Cindy were talking about, to talk about, how you all are prioritizing, the community mental health centers, the historically Black health professional schools, right? And their reach into communities with their group practices and so forth. The FQHCs. How do you all prioritize, groups, LGBTQ clinics, for instance, right? That we often overlook, or people with disabilities and where they go. So how do you all ensure that, the places where many of these individuals, if they can access health services, are included? Folks that we haven't traditionally brought into the clinical trial arena. Right.
Well, as I said, there is a great emphasis now on reaching out to underrepresented groups. That means a lot of the groups that you mentioned, because there's the acute realization in the research enterprise in general, and certainly at NIH, that we have been too narrow in our focus, that, in the old schools, right, research were only performed, in men. Women were kind of left behind, and there were so many other people left behind. Underrepresented minorities were left behind. Many different, we were not, a lot of the recruitment for a lot of the clinical trials did not reflect the population. And so we've realized that, and we're really making a lot of efforts to address it and really emphasize the importance of diversity in every aspect of the research. So what that means is that if there have been historically not a lot of research done on, for example, federally qualified healthcare, centers or centers that for whatever reason, are underrepresented. That's an area that is of specifically interest to NIH in general. It's also of specific interest, for example, to certain institutes that have made it in particular part of their mission, such as the Minority Health and Health Disparities Centers, but also NINR. I mean, you've stated it directly on your statement of the areas of focus. So, and so has NCCIH. So I think that's, there's no question that would be a plus for a study if it were to involve any type of unrepresented or poorly represented group. Does that answer your question?
It does. And so is this a requirement then?
No, it's an emphasis. It means that it would be a plus. It would be considered a benefit or bonus of the study if it involves underrepresented populations or healthcare settings, or it would be considered high program priority by the institutes that are evaluating by the reviews, because that is clearly stated as one of the priorities of the program. So when the grants get reviewed, the instructions that get given to the reviewers are, if it's in line with the strategic priorities of the program, then they're reviewed, with that in mind. So that's important.
Do we need to go on, or I have two more questions if we have time, but I'm happy to ask them later.
Yeah, I think we do have time. We're waiting for Dr. Stinson, it looks like. So please go ahead.
Okay, so these are two really, the first one is, you mentioned effectiveness. Cost effectiveness wasn't in there. And so NIH always sort of thought cost effectiveness was appropriate. And I was wondering.
Yeah, it's appropriate. Absolutely. Because when we think about, we want to inform stakeholders, including insurance payers. So cost effectiveness is something that's going to inform whether a particular approach is going to be implemented or not, right?
Sure.
So that's part of it. It's part of the data we need in order to drive implementation. If we know that a particular intervention is effective, but if it's in addition, if it's cost effective, that's an even stronger support for implementation. So
the other is it's very procedural question that I had is, does the coordinating center actually do their own reviews of these, or is it a regular study section?
No, the coordinating center does not review. The coordinating center is funded, so the coordinating center receives funds, but then all the grant applications get reviewed at NIH.
Okay. Those are my questions. Thank you.
Well, great. Any last comments or questions? Well, this has been a really great discussion. Alen, thank you. It's great to hear you're flexible in terms of imagining how the collaboratory can be adapted based on people's lives, the wide range of factors that affect their health, including those upstream. And I think it's also a nice opportunity to think about how we can build on what you've learned and done in the collaboratory, to think of new initiatives that we can work on together and with others to advance kind of new innovative models as we move forward. So thank you.
I totally agree. And I think this is where it would be very important to bring these new ideas, to the table and, and then, discuss it, saying, because by definition, the collaboratory is a living thing. As you can see, it's meant to evolve and adapt to the challenges of the times.
Indeed. So thank you so much, Alen, for joining us.
Thank you. Thank you for the opportunity to present.
Absolutely. Thank you.
Bye-bye.
All right. Bye-bye. So let's see. It looks like Dr. Stinson has come up, or he's been detained. So we'll see if he's able to circle back to us later. But we could perhaps, Rebecca, transition to the strategic plan, and then if Dr. Stinson is able to join, we can circle back that way. Does that sound okay?
That sounds right. Thank you.
Okay. All right. So let me get myself ready here. I'm going to share my screen. Okay, so let me know if that doesn't look right. Well, that's not helpful. Hold on. I'm really far behind. I'm like, good morning. It's like, that's from a long time ago. So hold on just a second. Let's see. Okay, how did I do? Does that look better?
Perfect.
Excellent. All right. So thanks for your patience. So we'll transition now to talking about the new strategic plan. I'll talk about where we are now and what to expect over the next few months. We're all really looking forward to releasing the plan and putting it into action. So NINR's mission is to lead nursing science to solve pressing health challenges and inform practice and policy, optimizing health and advancing health equity into the future. Ultimately, the strategic plan that we're going to be talking about next is meant to communicate to our stakeholders how NINR will advance this mission through the support of research and training. But first, let me begin with a note about nurses and nursing. Nurses are everywhere, in our hospitals and clinics, in our schools and workplaces, in homes and criminal justice settings, and throughout our communities. Nurses approach prevention, treatment, and care holistically. Our focus is the person in the context of their lives and their living conditions, not a disease or condition or a life stage. And it's our unique perspective that forms the foundation for nursing science and what we do at NINR. That's why our research needs to focus on the whole picture of health, from the biology of a person's cells and genes to their whole self, their family and resources, and the community and society in which they live. This strategic plan framework that I'll discuss in a moment was developed with extensive public engagement. So thank you to everyone who sent us your ideas and your feedback. We really appreciate your participation, your interest, and your commitment to moving the science forward. We've reviewed all the feedback we received, and it's informed our thinking as we've developed and refined the strategic plan framework. 20 external experts participated in a working group that provided recommendations through the National Advisory Council for Nursing Research, or this body. We received 385 online responses to our Tell Us What Nursing Research Means to You campaign. Over 100 emails were received in response to an open call for input on the development of the strategic plan. I participated in 80 meetings and presentations with external groups. And our request for information on the draft strategic plan research framework generated over 130 public comments. We carefully studied the input and the feedback we received. Overall, more than 50% of respondents to our call for input on development of the strategic plan explicitly supported a strategic direction and research topics aligned with social determinants of health, health equity, and community and population health. Only 10% of respondents explicitly supported maintaining the previous NINR strategic direction. Less than 40% of respondents did not explicitly indicate a preference for a broad strategic direction, but rather submitted a suggestion for research and training processes or recommended a specific research topic, the most common of which was caregiving or the nursing workforce. Regarding our request for information on the draft framework, overall, nearly 2/3 of our respondents supported the strategic plan framework. Just over a quarter were either neutral towards the framework or wrote about a specific science topic they would like to see included in the plan. Only about 2% were explicitly against the NINR strategic plan framework. The plan will provide a big picture view of the directions that NINR will be heading. NINR's strategic plan will include a set of guiding principles that we believe should drive all areas of NINR supported science, and 5 research lenses that describe broad perspectives by which to examine health challenges. The plan will also describe our intention to develop strategic imperatives as new health challenges and new opportunities are identified. We released a framework for the strategic plan late last year, as I mentioned, and asked for public comments. So let's take a look at what's in the framework. First, I'll start with the guiding principles. NINR's guiding principles describe important qualities that we think all NINR supported work should have as we move to the future. In considering awards for funding, the extent to which studies reflect these principles will be a factor in our decisions. We need to support research that's innovative, applies rigorous research methods, has the potential for significant impact on health and wellness well beyond the initial study sample, addresses equity, diversity, and inclusion, addresses today's challenges, and helps us be better prepared for the future, and provide solutions to optimize health across clinical, community, and policy settings. So what do we mean by a research lens? Simply put, what we're calling a research lens is a perspective by which to examine an identified health challenge. As we know, the field of nursing science is comprised of many, many different perspectives on what topics nursing science should address and how we should do so. In developing the strategic plan, NINR identified 5 lenses that we think best leverage the strengths of nursing science and position the field to continue to innovate and think even bigger to increase our impact. So let's take a look at the research lenses. So here's lens number 1, health equity. This is studies aimed at producing evidence needed to reduce and ultimately eliminate the systemic and structural inequities that place some population groups at a disadvantage in attaining their full health potential. Research lens number 2, social determinants of health. Research examining the conditions in which people are born, live, work, play, and age, identifying effective approaches to address social factors, positive and negative, and social needs in order to improve health outcomes. Here's research lens number 3, population and community health. Studies that address critical health challenges at a macro level by focusing on interventions that affect groups of people with shared characteristics or who live within a shared area. Research lens number 4, prevention and health promotion. Projects studying how to prevent disease and promote health, through the continuum of prevention, from primordial prevention that targets the underlying factors that increase risk of illness, to tertiary prevention that aims to reduce disease severity, symptoms, and progression, with a particular emphasis on eliminating health disparities. And finally, research lens number 5, systems and models of care. Research that addresses clinical, organizational, and policy challenges through the development, dissemination, and implementation of new systems and models of care, including those that bridge clinical and community care with social factors and needs. So more information on each of the lenses would be included in the strategic plan. As stewards of the public trust, we want to make sure that the way that we manage our programs is consistent with our guiding principles, funding the best science with the greatest potential in improving health equity. We want this strategic plan to be a living document that will allow us to explore new opportunities and respond to new challenges as the need arises. Each year, NINR will look across the health and healthcare landscape to identify the most pressing health needs and research priorities, what we call strategic imperatives. Those imperatives will form the funding initiatives developed each year. Across all of our programs, training the next generation of nursing scientists will continue to be a priority for NINR. To truly prosper as a science, we must work to create a strong, innovative, and diverse workforce fully positioned to address any upcoming challenge and opportunity. NINR will prioritize promoting diversity, equity, and inclusion in the programs and functions at NINR, the development of new investigators, and in the participants in NINR-supported research. We will also foster interdisciplinary research and community partnerships internally at the NIH and across government, and externally in the community. And as stewards of the public trust, we will continually engage in evaluating our progress and communicating the results of our activities and programs to the scientific community, the nursing community, and the general public. So here's what you can expect over the next few months. The strategic plan will be finalized and published on our website. We'll begin the hard work of implementing the new plan in the research we fund and conduct, and in the way we manage our institute. We're also considering hosting seminars and other events that will highlight important research in these new areas of emphasis. The bottom line is keep monitoring our website, our Twitter feed, and our news feed for the very latest. So, and now I want to open the floor for comments and discussion on the strategic plan. We'd love your thoughts on the application of the research lenses to areas of nursing research, translation of nursing research into practice and policy, and identification of pressing health challenges and critical research gaps and opportunities. So again, thank you so much, and looking forward to the discussion. All right, okay, I see multiple hands up. Nana's hand is in my face, so I'm gonna go Nana first.
Sorry about that. Well, I'm very encouraged by this new strategic direction. I think it's something we have needed in nursing research to expand the lenses of what we were doing in research. I think it also aligns very well with the NIH strategic plan, the overall strategic plan, and it also allows for collaboration with other institutes, therefore allowing for more nursing research to be funded when you co-fund with other institutes. So I think it's definitely the need is there for us to do this. Nursing has been doing social determinants for a long time, and it's a great opportunity, and I think it's the right direction, and it will further support for nursing research. So I'm really encouraged by this direction of the NINR.
Sarah, do you want to hop in?
Yeah, did you call me? Sorry. you're quiet. Yeah.
Yeah, you're the next.
Okay. Yeah, I did. Well, so I'm a little biased because I was on the framework group along with many other here. But I think, the time is totally right for this. I agree with Dr. Paragallo said about being able to work across institutes. I also think there are so many people in this country who were moved to try to change the way things are in the last 2 years, but don't really know quite what to do. And that this is a concrete step to put resources behind ways of changing our country. I think nursing, when you think about it, is really the science of well-being and how to increase the well-being of everyone. And there's so many ways to do that. I know that it's a shift from what has been in the past, but that some people will see it as a bigger shift than it possibly is. I think that the lenses is a really wonderful way of including all the nursing science that has come before as well, because of course with glasses or lenses, you can see anything. So you could, to take symptom science and palliative care and some of the other real specialties in nursing, one can continue to work on those through those lenses of health equity and social determinants and still work on symptoms, but also include things like, do people have enough food to eat, and the family context and perhaps the neighborhood context. So I think it's a really wonderful way of including all that we've done before and shifting it in a structural kind of way to meet the moment of now.
Thank you. I see your hand, Cindy.
Yes, thanks. So I do think this is a direction that really has been at the heart of nursing for a very long time. We've always been concerned with health equity and with meeting people kind of where they are and helping them move their health and their well-being forward. What I noted that on the website, the way that you articulated the mission statement right now is not on the website. So as external people are looking at that, they're looking at the framework without that context of what the disciplinary perspective is right now. And I do think nursing has a really unique perspective to bring, and that contribution is important. And I think it's really important to articulate for both our internal and external audiences what may not be obvious to them, and that is what is sort of the unique contribution of nursing to the science of healthcare. So I would urge you to kind of put that mission statement up as a way to frame the strategic framework as it moves forward, because otherwise it just hangs out as sort of a methodology or a lens and without the disciplinary grounding.
Yeah, thank you. Dr. Lewin?
Well, thank you. This is a great idea and initiative. The only thing which I would add is that I would really encourage you to include more engineering input and collaboration between nurses and engineers. I think that with the advancement of telemedicine and the idea of having treatment and patients home, the implementation of, let's say, wearable monitoring and wearable neurostimulation equipment is not possible without nurses' input. The engineers can come up with the design, but I think that they need the feedback from the field, and that feedback can only nurses provide.
Thank you. Do others want to jump in? I know Dr. Lowe also has his hand up.
Yes, thank you. I echo the comments and concur with the sentiments already spoken. And I too am very appreciative of this, the work that has been invested into creating the strategic framework. And I think as nursing leaders, we all have a concern about the next generation of nursing scientists, and we really need to be prepared to develop and lead our next generation. And so I think these lenses will really prepare us and guide us into how we will do that. And I really appreciate the focus on where we will lead the nursing scientist training and development, and that these lenses will provide that opportunity to do that. And so I think without a framework that such as what's been presented, we would not be, we would still be most likely be in the same situation where we currently are in thinking about, you know, what's going to happen with the next generation of nurse scientists in particular. And so I really support this framework. Thank you.
Anyone else want to react to what they've heard so far? Oh, Dr. Wolf.
Yeah, I just want to echo that. As we spoke, Dr. Zenk, this is a really bold and forward-thinking agenda, and I am very excited. And I think NINR is really leading the way in naming out front these strategic lenses. I think that, you know, one thing to sort of, I guess, ensure is that NINR has always been welcoming of non-nursing scientists who are able to leverage the priorities of NINR and nursing science. And I'm just hopeful that that will also continue. And I didn't see anywhere that the strategy is changing around that. So I'm just naming that. And I also, as a palliative care researcher and a pediatrician, what I am learning through these discussions is that you're really pushing us towards these really important questions in the context of our research agenda. So I think that's really helpful in that we're being, you know, made to be much more intentional in our studies around the concepts that are being put forward. And so I'm just expressing my appreciation for that.
Other things, new things you want to put on the table, reactions to what others have said or what I said? Well, we so appreciate all the input. I have had a chance to talk with each of you almost. I think everyone else, I have a couple people left just to hear directly from you what's on your mind. So we are really excited about the future. I really am so excited to be working with council, and we value your input, your guidance, your counsel as we move forward to make sure we get it right, that we continue to build nursing science and we continue to expand our impact and to optimize health and to advance health equity. So thank you so much for your commitment to the Institute, and I'm really looking forward, and I know everyone at the Institute is, in terms of working with you as we move forward. And with that, in direct response to Cindy, yes, we will be updating our website and making sure everything is up to date and we're able to communicate effectively with the external community. So thank you for bringing that up. All right, last chance. Otherwise, I think our next speaker has joined us. All right, well, thank you so much for that discussion and that feedback. So hang on a second, Nate. Let me get myself organized. Okay. Let's see. Oh no. Okay, hold on. I'm all thrown off. Okay. So I want to welcome Dr. Nathaniel Stinson. I am so delighted to welcome him, as I've had the pleasure of working with him on the Common Fund Transformative Health Disparity Program this past year. He's also really generously contributed time to the Institute to help us in a number of other ways this past year. So I'm very grateful to Nate. Dr. Stinson serves as the director of the Division of Scientific Programs at the National Institute on Minority Health and Health Disparities, where he oversees the extramural scientific programs on minority health and health disparities. Dr. Stinson holds a PhD in environmental biology from the University of Colorado, an MD from the University of Colorado Health Sciences Center, and an MPH in healthcare administration from the Uniformed Services University of the Health Sciences. He'll be speaking about the new NIMHD Multiple Chronic Disease Disparity Centers. Over the years, as many here know, NINR has supported research with people with multiple chronic conditions. So I know there's a lot of interest in this topic and the nursing science community. So welcome, Dr. Stinson.
Oh, Shannon, thank you so much. It is indeed a pleasure, to be invited, to talk with your National Advisory Council about our initiative on multiple chronic disease disparities. I enjoyed hearing your presentation about, your strategic plan in your institute, and your institute is one of the ones that really does fit well, as far as our institute's interest in the cross-cutting nature, and the commitment to fostering health equity. And I know we have we're working on current initiatives together, and certainly look forward to many more in the future. I'll go ahead and share my screen. Hold on 1 second. Try that again here. Okay, always got to remember to unhook the other monitor, or else it just goes haywire. So I want to talk about our new multiple chronic disease centers initiative that we instituted this year. And to give a little bit of background, even though this says FY 2019. Actually, the interest in multiple chronic disease extends back to 2010, where the Department of Health and Human Services actually put together a strategic plan to have all of its agencies focused on multiple chronic disease in individuals around the country. Interestingly enough, similar to what happens in a lot of initiatives like that, there really were not separate funds that were really set aside, to really support the particular initiatives. And over the past, decade, even some of the things that may have been started during that time kind of, ended and fell to the wayside. But in 2019, Congress provided 1-year funds for competitive revisions for chronic disease centers that are supported by NIDDK, NCI, NIAMS, and NIMHD. And the reason they did that is they observed that these institutes all had or we're all supporting, chronic disease centers of excellence, sometimes in the same institution, and there was very little collaboration, across these different disease, specific, areas. And so they made it very, very clear that they felt as though that there was some real benefit from a greater, collaboration, and gave one-time money in 2019. In 2020, they also gave one-year money to NIDDK, NCI, and NHLBI, again, to extend, the support of some of the centers they have, focusing on diabetes, chronic kidney disease, and obesity. I kind of look at those 2 years as kind of test runs as far as what Congress was interested in doing, because in 2021, the Appropriations Committee added $45 million to the NIMHD base to develop a multiple chronic disease centers initiative, in concert with NIDDK, NHLBI, NCI, and also, NCATS. And they really were interested in the establishment and supporting comprehensive research centers, really focused on the prevention, treatment, and management of comorbid chronic disease associated with, health disparities. And so instead of segmenting the funds to different institutes, they said, okay, NIMHD wants you to take the lead and develop these centers in collaboration with these other entities. This is just a very, specific legislative language that just highlights, what we all know, the fact that, a lot of individuals, and certainly individuals and populations who experience health disparities, often have more than one chronic disease, and often those chronic diseases are associated with some very common, risk factors, and that give us the opportunity to really address this in a more, comprehensive and holistic way, and find ways to really improve the health and well-being of health disparity populations. I just wanted to show just one graph here because it kind of highlights this issue. It may be a little difficult, to read the legend itself, but the red line is the non-Hispanic, African Americans. The blue line is non-Hispanic white, and the green line are the Hispanics. And the line here is the development of the second chronic disease. And you can see that for African Americans, they start out with a higher chronic disease burden than the other two groups. And they also develop that second chronic disease sooner than the white population, and the Hispanic populations. And I think it's somewhere around 4 or 5 5-year difference here. The white population, Hispanic population tracks fairly close, but if you kind of notice a little subtly here, is that when the population hits that second chronic disease, the slope of that curve does increase, somewhat. So they have a higher rate of acquisition of additional chronic diseases as compared to the white population. And so the real purpose of this initiative was really to support regional comprehensive research centers on the prevention, treatment, and management of chronic disease that disproportionately affect populations that experiences health disparities. We really focused, but did not limit, any particular projects, to a set of chronic conditions that we felt were, very prevalent or had substantial, impact on the health and well-being of populations. Ones we're all very familiar: obesity, diabetes, hypertension, cardiovascular disease. But we also, threw in, chronic liver disease and also osteoarthritis. And of course, certain cancers included in that group as well. And really, the rationale is that, these conditions are common, and they all often coexist in individuals. And we really did require each of these centers to address 2 or more of the chronic conditions that commonly co-occur or share common social context, etiological pathways, or risk, factors. Similar to our institute's philosophy around centers, we have some, standard, components in our centers of excellence. Of course, the administrative cores where, just the management structure, but we also always have an investigator development core. And within the investigator development core, we require pilot project programs that provides opportunities for, postdoctoral fellows and early career faculty or other early stage investigators, especially from backgrounds underrepresented in the biomedical workforce. We feel one of the best ways to learn is to do, and so having centers that solicit applications and support pilot projects has really revealed itself to be, one of the best ways to help, early investigators gain that knowledge and that experience and expertise as they think about, moving along that continuum in their career. Community engagement core has always been, one of the components of our Center of Excellence that we have always felt that a good, productive, bidirectional working relationship, with partners and organizations in the community is instrumental in members of the community really to be able to benefit, from the outcomes from the work that occurs within, health disparity centers. And of course, research projects. All the centers were able to propose up to 3 R01 level research projects that focused on some aspect of multiple chronic disease, and we encouraged, very heavily that the applicants think about these research projects being some type of, interventions, in that we were much more interested in things that the project could actually develop and deploy than any type of descriptive type of research projects. We received 26 applications. They were all responsive, to the funding opportunity announcement. 10 of the applications were not competitive, meaning that they were not discussed at the review meeting, and 16 of the 26 were actually discussed. I'm just going to run through very quickly some of the projects that these centers have implemented, just to kind of give you just a flavor of the different type of projects that they're planning to implement, and then I'll just kind of tie things a little bit at the end, where I'll talk about where I think we can go and how we can work with the Nursing Institute. This particular project in Southern California is really testing parent-only interventions of a culturally relevant program in the treatment of overweight and obesity, and to reduce the chronic disease risk in Hispanic children and their parents. You'll see a theme in some of these projects where this intervention is really using a telehealth type of intervention as a way of trying additional modalities of deploying different interventions to address the particular risk factors. This project at the University of Alabama is really developing a multi-level and scalable intervention, to improve control of type 2 diabetes in low-income African-American adults, and also to mitigate potential cardiac and renal complications by targeting relevant social determinants of health. And there's really three components to this. One is digital, health coaching. One is free box delivery of foods, and also remote patient monitoring. This, a project in Minnesota is really implementing an intervention that's really designed to reduce screen time and intake of unhealthy foods with added sugar in overweight Hispanic children. Native American and Hispanic, sorry. This is a very interesting project in several institutions in Chicago that's implementing a exercise tool that's targeting morbidly obese homebound older adults and their caregivers. That is using voice activated technology, a mobile application and a smart voice speaker that's tied into existing physical rehabilitation content that was developed by the National Institute on Aging called Go for Life. And Go for Life really focuses on strength, it focuses on stretching, and all these exercises are intended to be done, in the home with, equipment that, or I should say, either with equipment that you could purchase and use in the household, or actually household items that can serve the place of other types of equipment. This project is one in LA County that's building upon the existing safety net clinics in LA County, and is an intervention that has expanded on the traditional healthcare team to include pharmacists to manage medications and address health and medication literacy, community health workers, and also the use of technology, and including Wi-Fi enabled blood pressure monitors, video visits, and also the development of a patient portal so that they can have more real-time interaction with their providers. Linked Heart, this is out of Johns Hopkins. Again, is a program that is developing intervention that expands the traditional team to also include community health workers and pharmacists as part of their intervention as well. This particular, center is a community and academic partnership that is also using community health workers to address dietary factors and also, risk factors for colorectal cancer. And they're adapting an existing evidence-based, web-based lifestyle program that has been shown in several clinical trials to improve cardiovascular outcomes. This project is focusing on the risk of heart failure, and it's also focusing on, addressing the social determinants of health as a mean to prevent progression, towards, health, heart failure. This is a very interesting project. One of the areas that we would like to see a lot more work done is in the area of rural health. And this project out of the University of Arkansas is designed to evaluate the effectiveness of a school district-wide comprehensive nutrition policy intervention in several rural areas of Arkansas to change BMI in the kids. The last one here, just wanted to show you that we do also have some projects that are focused on obstructive sleep apnea and interventions to really kind of address the treatment therapies and to mitigate, some of the downstream, negative health effects of OSA. I think this is the last one I'm going to mention here as far as the different type of projects that we have. Again, we really have asked or have encouraged the different centers to think in a multi-component, multi-level, multi-domain way instead of just narrowly focusing on one aspect or one particular risk factors. And this one, again, is really focusing on, multiple, domains as a way to really address, the risk of cardiometabolic disease. The last thing I want to mention, we felt as though it was very important to have a coordinating center as part of it. This particular group at the University of California, San Francisco have a strong history of being supporting, coordinating of centers, and essentially here are the things that we really wanted them to do, really to promote the collaboration and communication among all of the chronic disease centers. We also wanted them to be kind of a data hub and kind of a data analysis resource for all these centers, and we also wanted them to be supportive of creating educational and skills development opportunities for the investigators that are located at the different chronic disease centers. So that's kind of where we started with this program this year. It is our hope that or it is our plan, let's say it that way, to really build upon this and potentially, find ways to even enhance the collaboration across, these different centers, and also look at expanding the number of centers, because there are still areas of the country that we think that would be would benefit significantly from the expansion of this consortium to a wider geographical area, and we would certainly love for the Nursing Institute to be a partner with us, and not just not asking for money, but really the intellectual value that the Institute can can bring to the table as we implement this initiative. Thank you very much, and I'm happy to answer any questions.
Thank you so much, Nate. So appreciate that. Let's see, who do we have for discussion? I think we asked Dr. Johnson and Dr. Wolf to kick us off. Dr. Wolf, I see your face. Do you want to go first?
With pleasure, thank you. Thank you so much for the presentation and this program, which is, again, Dr. Stinson, extremely robust and tackling such important issues. I had a couple of observations, and I'm just curious, some of the outcomes of the, sort of the funded areas. It seems to focus heavily on cardiometabolic issues, a higher emphasis, of course, in adults than younger patients, although there was nice to see some pediatric research focus. And very little focus on, except for that one project on policy, which I think is, I heard you say you'd like to see more of that, which I think can really affect change. The chronic disease that I'm wondering, I didn't see on the list also about is mental health and the sort of synergy between disorders like attention deficit disorder, for example, and issues related to all chronic diseases. So those are the sort of the general category I'm wondering about in terms of those areas of focus.
Sure. So a couple of things. We were careful when we were listing out the particular chronic diseases to include the ones that Congress said that they wanted to see the initiative on, and that's why we said, but not limited to. And when we had our technical assistance webinar, we did mention some others, and mental health was one of the ones that we did mention that certainly would fit what we're trying to accomplish. You have certainly raised an issue that we were always very concerned about, in that we didn't want to be too directive about what people could come in and submit applications, but we were also concerned that we may get too many applications focusing on on kind of the same thing, and of course, you rightfully so, you picked up on the large number that really did focus in that particular arena. That's really why in our discussion so far, as we think about building on upon these centers or this initiative that we have, should we have the resources to expand, we would be a little more directive about what we were interested in to kind of fill out that breadth of different diseases and conditions, and ages, as you mentioned, and geographies, to where we really think that consortium, especially since we're going to be collecting some common data elements among all of them, is something that will have a great impact. But clearly our mind is thinking is that, okay, that's step one. This is what we have. What are we missing? And how do we really move the initiative as a whole to be, as broad as it really needs to be. But your insights are perfectly right about what it looks like at this point.
Thank you.
Mallory Johnson from UCSF, which happens to be the coordinating center for this. I've talked to the PIs of the coordinating center here. It's quite a huge initiative, and it's very exciting, and I'm very impressed in some of the same reactions that you just heard in terms of the breadth of conditions of focus, of populations, of developmental age groups. and also the settings and the regions and rural versus urban. There's and also the types of interventions that are being played out here. I was curious from your perspective, how do you approach coordinating such a large machine with so many different moving parts with different focus areas? Like you're saying, there are going to be some common data elements, but I would imagine also just huge variability and everything else. And I'm just curious from NIMHD's perspective, how do you see something this large going successfully, given all the many players and many parts?
Yeah, it's a particular challenge for something that is this large and this broad. Philosophically, our perspective is to try to foster the effort as more of an alliance than a consortium of places that NIH is basically funding, and so that there's a sense that the collection of the centers are really driving the outcomes versus responding to what NIH is saying. And I'll tell you what I mean by that. One of the biggest mistakes that NIH can ever do, and we do it from time to time, is to go to a set of institutions and say, we want you to do this, we want you to collect these common data elements. Versus what we did here is that we told everyone up front, that was applying for a center, and then also the coordinating center, is that part of that initial process was going to be the centers and the coordinating center developing those common data elements. We'll give you certain suggestions of tools to look at, like Phoenix and others, but we want you as a grouping, as an alliance, you come up with the ones that really make sense and that you believe as seasoned investigators are the ones that really will make a difference as far as having some utility in improving the health of individuals and communities around. So that's the first thing, is that let's not make this top down. Let's have the group act as a collective, as basically an alliance. And the second thing that we also try to do is really empower the coordinating center in a way that we make sure that they have the resources they have to be enablers for what the other institutions need. And that includes giving them the freedom to basically go out there and find out, what is it that you need? What are you? Let's not make certain assumptions that this is what you need to do as a coordinating center. These are the things you need to execute because this is what NIH, is put in your, notice of award. I don't know all the things that UCLA needs. I don't know all the things that the University of Minnesota may need in their program. But we'll give resources, to and flexibility in the utilization of those resources for the coordinating center to be able to adapt and to be able to develop what they need. Not saying you need to have these set of of particular activities. We at least we believe that that's been fairly successful in our other centers program, and this is clearly what is the approach that we're using here.
Great, thank you.
Can help coordinate here. So Cindy, do you want to jump in?
Yeah, thanks. So I have two questions, but I'm going to just ask one first.
Okay.
And as I'm looking at the curves that you had for the Hispanic and for African American populations and for the white population, it looks like if the intent is to bend those curves, that it really is going to require an emphasis on prevention, not only on the other two pieces of treatment and management. And I wondered if there has been any attempt to shape the portfolio in a way that would favor intervention that is focused on prevention rather than exclusively on treatment or management of existing disease.
Yeah, that's a great point. I mean, if you look at the different, research projects, there's a mix of things. So some are, focused on prevention, and others are, much more on the treatment side, especially the ones that have some type of activity in the healthcare setting, whether that they're, community clinics or other type of, basically other type of facilities. I couldn't agree with you more. To really bend those curves, it's going to have to be on the prevention side of things. And again, that's part of the discussion that we're going through now as we think about expansion of this in this next year. I clearly talked about, particular, disease, areas and geographies, are all part of our basic thinking. But within that discussion is also what type of research, projects, do we want to see? I clearly could see, a next iteration of this really focused on, interventions or projects that are targeting, purely on prevention of, or mitigation of the risk factors that lead to the multiple chronic disease conditions. All those, I think, all those options are on the table. I mean, it sounds a little wishy-washy, but I believe my expectation, I guess is the best way to put it, is that when we think about this the next step on this, we'll be very, very thoughtful, and really decide where really is the bang for for the effort here, and what is it that we're not doing that we should be doing, and I could easily see there being a disproportionate reliance on studies that really do focus on prevention. You had a second question?
Cindy, you want to ask your question? Go ahead.
I'll wait and I'll follow John Lowe.
Okay. Well, what this sort of warmed my heart, because I know, like, both Sarah and I are closing down centers that were funded by NINR, and that center program is going, but they were based on multiple chronic conditions, and that was the theme. And I could see this being put out to the people in the past that have had centers as another way to sort of meet those needs. And I just wanted to, sort of bring that up, that, there's a lot of people, nursing scientists, that have led centers. The last call was for multiple chronic conditions. It wasn't about health disparities, but I think that makes total sense. And I just think there's some real synergy here that people could figure out. So it wasn't a question, it was a comment.
I think it's a great fit, and I think part of one of the things that we encourage in these conversations is for everyone to go back to their contacts and get them thinking about possibilities should something actually be able to build upon, any particular initiative, that we have. We would love to see, your investigators, come in.
Great. Dr. Lowe?
Yes, thank you very much for that description and the details. Is very interesting and informative, and thank you for that. So I'm curious, I did not see that when the data was presented about the chronic illness burden curves, I did not see data regarding Native Americans, and was curious about where you're at with that and why that was not there. And also, it looks like most of the P50, if I was following it correctly, there was maybe one project that was related to and focusing on Native Americans. But so I'm kind of curious if there are not applications coming in for this mechanism, or they're not doing well. So appreciate that. Thank you.
Well, the short answer to your question is we were disappointed, in the range of applications that were focused on different, populations that experience health disparities. There's just no question about the burden of disease that occurs in many of the American Indian, Alaska Native populations. And, we would, have loved to have had, a center, because there are institutions around the country that actually are focusing on those particular populations, to come in, and, to receive, an award under this particular initiative. And, my fingers are crossed that, should we go out with another solicitation, in the near future, that institutions will come in, with proposing work with with the populations. But it was just a matter of, the applications that came in. I was actually expecting more than 26 to come in, to be real honest, just based on the number of places I know that are doing this kind of work. And some of it may be related to, competing, priorities. I think we gave them a little more than a minimum of just 60 days, but sometimes we know that really, puts a burden on the extramural community if we don't give them enough time to really, write center grants. So we certainly are committed, if we go in the future, to have a longer length of time for people to write applications. But we really are approaching this as it's not one and done. We're not going to basically say, okay, we did this, and everything is good, for reasons many of you are mentioning, the fact that there are a lot of other chronic disease, multiple chronic comorbidities that aren't represented, in this first grouping of of 11 different, centers. Should we have, resources to do it? This area is important enough, that it should be a priority of investment. That's my, point of view on that.
So I just had a follow-up question to Dr. Lowe's questions, and that is, there are specific centers for Latino and for African American and for Asian health. And my question is, have you thought about shaping the portfolio in a way that either addresses additional groups who have health disparities, or taking a more global approach, as some of the other centers did, to health equity rather than identifying specific populations? And I asked that because you've said, that you sort of took the proposals that came in, but really the funding announcement can shape those priorities as well. And I wondered if you had any thoughts about shaping the portfolio in one direction or the other.
I think that what I expect will happen for the next round, if we're able to do that. I think that we will indicate our interest in areas that will broaden out our portfolio. Unfortunately, there are too many populations that experience health disparities, and we want to kind of create an enterprise here as far as this initiative is concerned, to try to support the research that actually is going to be beneficial to all the different populations that experience the health disparities. So sure, I could clearly see language in our in a future funding opportunity announcement that makes it very, very clear that that our portfolio is this. We're very interested in projects that are going to do these type of things or work with these particular communities. Makes all the sense in the world from our perspective.
Thank you. Well, thank you for that great discussion. So Nate, I understand you have a commitment maybe right now starting, so I do want to let you move along. We so appreciate you joining us. Thank you so much for sharing more about the centers, and looking forward to talking more as we move forward.
Well, thank you very much for the invitation, Shannon. I also want to say hello to Nina, who I have not seen in a very long time. She's one of the first people I met when I came to NIHD, because she was on the council. So it's nice to see you. You're looking very well. So thanks. I just want to also thank everyone. Your comments were very, very helpful and insightful. And please rest assured that when we go back and start thinking about the next phase of this, we're counting on being in a partnership with the Nursing Institute, and look forward to sharing with all of you the new centers that we have that will probably hopefully be representative of a lot of your investigators as well. So thank you very much.
Thank you, Nate. So we've made it through our open session agenda. I want to thank Council for this excellent discussion today, for your advice and your feedback. We greatly appreciate it. And, let us know if we made a good use of your time. If you have feedback on how it went today in terms of adjustments you want to see, we're all ears. So welcome your feedback at any time. So with that, Rebecca, correct me if I'm wrong, we're going to break for a bit before we go into closed session.
Well, we still do have to do two concepts. So
oh my goodness. Well, how about that? I was like leaping ahead. We definitely want to do the concepts. So tell me what we should be doing, Rebecca. Correct me.
So we could take a brief break now, because the concepts will be about half an hour, followed by discussion at the end of the council open session. So we could take a 10-minute break now and then resume, take care of that, and then start the closed session at 4:15.